Good afternoon, everyone. This is the Missile Community Cancer Study Town Hall. Thank you so much for being with us today. You can see the email address that we have listed on the screen to be able to send questions. But otherwise, General Davis, sir, over to you.
Hey, good afternoon. I'm General S.L. Davis. I'm the new commander of Air Force Global Strike Command. Welcome to the Missile Community Cancer Town Hall. As you know, I took over this effort from General Bussier, who started it. I tracked it very carefully as it was going on, and now I find myself in charge of it. This issue is personal for me. I'm a career missileer, so it affects me in some ways. When my father passed away from non-Hodgkin's lymphoma, that he got probably from his exposure to the color agents during Vietnam. So this hits very close to home for me. It's important. I am committed to following this to its logical end and making sure that we understand the environment that our missileers and the associated personnel in the missile field are in, understanding those environments, making sure that they're safe. So with that, I'll turn it over to Colonel Coleman, who's going to run us through the town hall briefing.
Thank you, General. We go to the next slide. Well, good afternoon. Command Surgeon here at Air Force Global Strike Command. I want to thank you for joining us today and the opportunity to really share updates on the progress of the study and the institutionalized processes to take care of our airmen in the missile community. Over the past 3 years of this study, we have remained steadfast in our commitment to ensuring a safe environment for the missile community, and doing so in a transparent manner that assures our commitment lasts well beyond the study. We've used these 3 distinct study objectives to guide our efforts. We first studied the as-is environment at the 3 active missile wings. This effort accounts for those members currently serving in our missile fields. The results of the as-is environmental assessment shape the institutional processes we put in place to document and communicate risk for our airmen and their families. Finally, we conducted an epidemiology review to understand the scope of potential exposures for DOW, separated and retired members, families, and our VA partners. We go to the next slide. A study of this magnitude does not occur without great partners, and the Air Force School of Aerospace Medicine, or USAF-SAM, remains an excellent internal partner. We also want to share with you some of the external partners that are instrumental in this process to ensure we provide a comprehensive and complete assessment of the missile community. Here you see many of the agency reference to ensure that our methodologies are sound and we deliver accurate and validated work to the community. Today we have Dr. Timothy Crawford from Wright State University joining us, and we'll discuss the epidemiology review. Not pictured on the slide, but also joining us is Dr. Christine Duran from the 711th Human Effectiveness Directorate. And I want to thank both of them for being with us today. To the next slide. As this may be the first town hall for some, I will provide a brief overview of the study timeline to address the question posed in December of 22 of whether the missile community has an increased risk for cancer. We first needed to study the as-is environment to learn from the missile operators, the facility managers, and defenders who live and work in the missile alert facilities. So in the spring of 2023, a team of experts, including bioenvironmental engineers, public health, and occupational health experts from USAF-SAM, traveled to the missile wings to ensure we address the missile community's concerns, accomplish an initial site assessment, and begin the study design. Based on the initial visits, we identified a few immediate adjustments to aid in ensuring a safe working environment, ranging from updating radio frequency signage, adjusting parking locations to prevent exhaust fumes from entering the missile alert facility, and stopping the activity of burning classified material in the enclosed launch control center. From there, working with the National Institute of Health, we were able to design a very comprehensive study that incorporates 2 major lines of effort. The epidemiology review, which compares 14 common cancers in the general population with those in the missile-related career fields. The review looks at the incidence of cancer rates and requires analysis of specific data sets to ensure we are addressing those who are currently serving and those who served in the missile fields across the nation. The second part of the study is the environmental sampling effort, which is divided into 3 seasonal rounds to account for any seasonal variations. We sampled the air, water, soil, and radon to ensure a safe working and living environment for the missile community. The data collected from these 2 lines of effort informed how we structured the institutionalized processes to document potential risks to airmen. During the environmental sampling effort, which took place from the summer of 2023 through the fall of 24, we sampled nitrates and nitrites testing to track water quality fluctuations, sampled the air, soil, and water for organophosphates, looking at pesticides and seasonally assess fluctuations based on farmers' spray schedules, and polychlorinated biphenyls, or PCBs, that are found in electrical components in the missile alert facilities. The environmental sampling effort collected over 8,400 samples and captured more than 100,000 data points to be included in the development of the comprehensive health risk assessment to assist us in understanding potential hazards in the environment. Committed to safety and transparency, during the first round of the environmental sampling, 4 of 900 PCB surface swipe samples were detected above the EPA recommended standard, and all 90 PCB air samples were non-detectable. The 3 missile alert facilities with results that were above the recommended standard were immediately closed. They were cleaned or mitigated before allowing our airmen to return. In addition to those immediate actions, the Air Force Global Strike Commander issued a memorandum stating that despite a comprehensive removal effort in the 1990s, there remained a continued presence of PCBs. And while we are unable to sample decommissioned sites for the Peacekeeper or Titan weapon systems, a technical order review showed that the PCB containing components were likely used in those alert and control facilities as well. This memorandum was shared with the VA and posted to our Missile Community Cancer Study website for our separated members and veterans to use with their primary care providers as they seek care for any health-related concerns that they may have. So throughout the fall of 23 and spring of 24, environmental sampling of the air, water, soil, and radon continued to assess for seasonal variation. And the environmental sampling also expanded to include Vandenberg Space Force Base as well as Hill Air Force Base. Also during that time, we released Phase 1 Alpha of the Epidemiology Review, which looked at the military electronic health record data. This limited data set found no increase in non-Hodgkin lymphoma, but a potential trend toward an increase in breast and prostate cancer. The expanded but still incomplete data set in Phase 1 Bravo did not identify an elevated incidence of non-Hodgkin lymphoma or any of the 13 other individual cancers in the study. Phase 1 Charlie of the Epidemiology Review did not identify statistically elevated mortality in the community compared to the U.S. population. The Epidemiology Review continued with Phase 2 and a review of the state registries. In the spring of 25, we shared the results of the Comprehensive Health Risk Assessment incorporating all 3 rounds of environmental sampling results. USAF-SAM's assessment was the risk was low, but not zero, and the recommended implementing occupational shops, which the command implemented in 2024 as part of our commitment to institutionalizing processes to document and communicate potential risk for the missile community. We also began the process of studying the former activity of burning materials with accelerants in the launch control centers. Today, we will provide updates on Phase 2 of the epidemiology study, the burn study, and provide an update on our institutionalized processes to ensure a safe operational environment for the missile community. Slide. We'll begin with some of the ongoing activities at the missile alert and launch facilities. Next slide.
Good afternoon, sir. The ICBM Maintenance Division, working with the Program Office, has walked through all of the associated ICBM maintenance technical orders and civil engineering manuals, standardized PCB response procedures, warnings, cautions to make sure we've level set across the ICBM community. We've updated signage warning of possibility of exposure to PCBs. We have validated that current and past locations that have or could have contained PCBs are appropriately marked, so our technicians have appropriate warnings. And to ensure that's an enduring fix, we've added that signage to our periodic maintenance inspections to make sure this isn't a one and done, and then we have the same problem 10 years from now. Periodic maintenance inspections have also been reviewed and adjusted to guarantee good airflow in the LF and LCCs to improve the working and living conditions. We have, working with the A3 community, implemented LCC cleaning contracts for general hygiene and working conditions in all of our LCCs. And we have implemented a PCB cleaning contract for LCCs. We started with LCCs with out of tolerance readings as a result of the PCB testing, and now we're rolling through all LCCs to make sure we get a good industrial cleaning to remove any possibility of PCB contaminants. As a follow-on effort based on the last town hall, we are now working through all the historical data that the program office has available to identify any other possible hazards that could have been present in previous weapon systems. Any questions? That's all I have for us.
The next slide. As part of our commitment to institutionalizing processes to document and communicate potential risk, in 2024, we created occupational work environments for the missile community and are documenting all of our environmental findings. For the members serving in the missile community today, they will have any potential exposures tracked in the Defense Occupation and Environmental Health Readiness System, or DOORS. Creating the occupational shops included conducting interviews with the supervisors, understanding the work environment, conducting assessments for local health risk, and then in turn entering the members of the work center into DOORS. This system allows us to track any potential hazards exposures for the community. The process and the system ensure we provide the appropriate medical surveillance to the community. So as we're looking at this particular graphic, you see at the very beginning on the right-hand side is where we work with the supervisors in the unit and identify which members need to be part of that shop. At that point, we assess the environment by doing monitoring, and whatever the monitoring tells us, then we're able to work with the key stakeholders and leadership to understand those risks and make some risk control options. That options might be cleaning, as Mr. Miller has described, or using certain protective equipment. And then we monitor that finally through safety inspections in the workplace and assessing the community via medical surveillance where appropriate. And so if we go to the next slide, when we enter DOORS communicates directly with the individual longitudinal exposure record, or what we call ILR, which is visible to both the DOW and the VA. The connection of these two systems ensures members separating or retiring have a complete exposure record at the end of their service. In previous town halls, we discussed our efforts working with the ILR working group to grant individuals access to their ILR with a common access card. As of 23 March, that access is now available. And for those without a common access card, the ILR working group has continued to work in access for our veterans using a login and password. The ILR compiles an electronic historical exposure record that documents a service member's potential occupational and environmental health exposures over the course of their career. Known exposures, events, and incidents are linked, and the ILR also includes clinical and environmental information, deployment history, context, event-driven incident reports, and registry data. Next slide. By linking service member and veteran data to known exposures, ILR supports individualized healthcare. Individuals will be able to add relevant information that might include deployments, garrison locations, registry, and other exposures information that weren't already included in their ILR. Now, ILR is not a complete or flawless record at this time. It will continue to evolve and expand. Some historical exposure data may be missing, particularly from older data systems or undocumented incidents. ILR is intended to complement a thorough clinical exposure history and individual self-reporting. So on the screen, this is a screenshot of what you'll be able to see once you access it. And then on to the right is the Add My Eiler feature, where you'll be able to update the system for things that may be missing from your record. Now, there are some known errors, such as incorrect initial start dates are recognized as by the Defense Manpower Data Center system. And that is a coding error that is undergoing analysis for correction now. Well, this is a great advancement and one that helps us achieve a goal of institutionalizing a process to document potential exposures. Accuracy of this record is still a work in progress. So as you go in and access it, there might be some duplicative information in there, but this first progress allows you an opportunity to have more agency over your individualized healthcare as you discuss your healthcare with your healthcare provider. Next slide. So burning of classified materials is one of the practices immediately halted during our initial assessment, as we partnered with the 7-Eleven Human Performance Wing to evaluate potential adverse health effects from this historical practice. Next slide. Yusuf, Sam, over to you.
Yusuf, Sam, are you guys up?
Okay.
Now we're,
All right, over to you.
Okay. The objective of the burn study was to determine whether the discontinued practice of burning controlled items in launch control centers may have contributed to past, present, or future health effects. The burn study was conducted in multiple phases. First, as shown in the black box on the left, the controlled materials were burned, either by themselves or with a mixture of accelerants and other materials as provided to us by Air Force Global Strike Command A30. The complete list is available in a couple of slides. The materials were burned in an ammunition can. During the burns, chemical emissions were either measured in real time or collected for offline analysis using a combination of advanced analytical and computational techniques, and that's what's shown in the second black box. Next, shown in the third black box, the measured burn properties of the materials were inserted into a simulation to determine the distribution of emissions within three-dimensional virtual geometries of the launch control centers at F.E. Warren, Minot, and Malmstrom. Concurrently, as shown in the gold boxes, chemicals identified were evaluated with reference to exposure thresholds and existing toxicity data, or run through models to predict toxicity where data was unavailable. The blue boxes describe all the steps completed by toxicologists and predictive risk modelers to reach the delivered health risk assessment results for cancer and non-cancer risk, which is what is shown on the right in the purple boxes. For cancer risk, the threshold of 1 in 10,000 was used to determine whether there was an elevated risk as validated by the National Institute for Occupational Safety and Health. For non-cancer risk, the hazard index approach was used, which evaluates the simultaneous effects of all chemicals exposed together as a mixture. For both the cancer and non-cancer health risk assessments, it was conservatively assumed that 8 burns per month persisted for the entire period working at the Launch Control Center, which equates to approximately 100 burns per year. We assumed the working period to be 8 years. Slide. As a refresher from what we previously described in October, we measured for 4 combustion gases, 89 organic compounds, 26 metals, ultrafine, fine, and coarse particulate matter, and analyzed the gas chromatography mass spectrometry data for additional organic compounds, which may not be in the target list. In the end, we found that the emissions were comprised of combustion gases, ultrafine and fine particulate matter, and a mixture of organic compounds such as aldehydes, aromatics, and polycyclic aromatic hydrocarbons. Measured burn properties were inserted into physics-based models with burns simulated at both the catwalk and T-junction near the elevator shaft in the FE Warren layout, and catwalk Maelstrom layout to predict exposure concentrations at 8 locations in the acoustic enclosure and 7 locations in other areas of the facility, including observers positioned near the burns. The graph on the bottom right includes total emissions exposures as a time series at 2 of the observer locations and 2 of the locations within the acoustics enclosure. As expected, the concentrations were relatively higher at the observer positions versus in the acoustics enclosure. So that the observer positions are shown in the gray and the red on the plot on the bottom right. The worst case scenario results from the simulation at all 3 bases and locations were used for the cancer and non-cancer health risk assessments. Slide. For the cancer health risk assessment, we used the worst case scenario concentrations from the simulations extended to a 24-hour time weighted average exposure to account for residual emissions present after the burns. Then we calculated the cumulative excess cancer risk for the carcinogenic chemicals identified, assuming 100 burns per year for 8 years. Air Force Global Strike Command, A30, provided the components for the mix typically present in the burns, and this is listed on the slide. Excess cancer risk for all burn experiment conditions was less than the threshold of 1 in 10,000. The addition of WD-40 as a secondary accelerant reduced the cancer risk value, and all of the values were below the threshold. To put all this in perspective, according to the American Cancer Society, smoking cigarettes leads to a lifetime excess cancer risk in excess of 700 per 10,000. Slide. For the non-cancer health risk assessment, we used the worst case scenario concentrations for the 15-minute time weighted average. And then we calculated the hazard quotient for all chemicals identified using the most conservative exposure threshold to calculate a hazard index, which accounts for simultaneous effects from all the chemicals present in the exposure. Just like the environmental assessment, we chose the most conservative relevant guideline, meaning the least amount of extrapolation to adjust to the exposure time of interest. You will see in the table that different agencies' thresholds were used for different chemicals for that reason. The 8 chemicals listed in the table on this slide were found to account for over 97% of the contribution to the hazard index. The Defense Centers for Public Health, which establishes military exposure guidelines tailored to protect the active duty population, further categorize exposure thresholds as negligible, marginal, critical, or catastrophic. For this study, we compared the hazard quotient to the negligible and marginal thresholds. A negligible effect is defined as few, if any, health effects, whereas a marginal effect is defined as noticeable but not incapacitating health effects. For 2 of the 8 chemicals, there was no exposure threshold available for marginal effects. Therefore, the hazard index in bold for marginal effects indicates that the value is likely greater than 0.54, and the exact value is an estimate. When the toxicologists looked into the data that was available, they identified that the hazard index would still be less than 1 for the marginal effects. And for completeness, the hazard index for both marginal and negligible effects with those 2 chemicals removed are shown in the second row below that bolded value. This allows for an apples to apples comparison. The hazard index was greater than 1, which is the threshold for negligible effects. This means that it is possible that the exposure from burning controlled materials could lead to minor eye and respiratory irritation, but these effects are expected to be temporary and not to be incapacitating or lead to long-term health effects. Slide.
Well, thank you, General Davis. and the Air Force Global Strike Command, and everybody here interested in the missile community. My name is Colonel Speakman, and I'm the commander of USAF SAM. Slide. As a review, this is where we have been in our epi team arm of the study. Phase 1 incident results were presented in October of 2024. There was no statistically increased risk of cancer in the missile community. This was based on approximately 55,000 identified cancer cases from the entire active duty Air Force for members who had served from 1976 until 2010. We had urged the community to hold off on drawing any conclusions until we had had the opportunity to include cancer data from additional data sources. Phase 2 now includes that significantly larger data set with nearly 2.7 more cancer cases identified, getting this study much closer to finally being finished. Slide. This timeline illustrates the collection process for the Virtual Pooled Registry, or VPR data. The VPR cancer linkage system is a collection of participating state and territorial cancer registries. When the MCCS started, there were 44 participating registries that provided matches for our cohort. Today, we are discussing the data gathered from over 200,000 records from 43 of those 44 cancer registries, including all states with an active nuclear deterrence mission. It is worth noting that 43 registries ties the current record for the greatest number of cancer registries ever used in a single study. This achieved an estimated data completeness of 97.3%. But just this week, our team received the final data set from North Carolina, which is now a new record for the most VPR cancer registries ever used in a single study, bringing our VPR data completeness to 100%. Since we did just receive the data from North Carolina, it is not yet included in this analysis that we are discussing today, and we are actively rerunning these numbers. The common question is, why does this epidemiological study take so long? In September of 2024, Ohio was the first participating state that sent us their data. There has been a dedicated team working with multiple states to acquire their data. Florida reported in just this past Christmas holiday, and Kentucky gave us a New Year's gift to welcome in 2026. And as I stated, North Carolina gave us their final results just this past week. We know that our numbers will change as we add in the North Carolina data. However, we do not expect the overall results or conclusions discussed today to change. Slide. Here you can see the impact of the additional data as our case counts. The total number of cancer cases analyzed has increased from approximately 55,000 in phase 1 to now over 148,000 in phase 2 after we have deduplicated the data from the states. The table on the left breaks down the cases by the 14 different types of cancer, comparing the micellar community to the non-micellar community. It details the number of cases and percentage for the total of each cancer type within both groups from the period between 1976 and 2020. The exact numbers will change when we add in the North Carolina data. While these numbers provide an important perspective on the scope of cancer in the missile community, this also represents the impact of cancer on the entire Department of the Air Force community. Behind each statistic, each number or count is an individual. It's a life impacted. It's a family reacting and a community deeply affected. These figures represent not just cases, but real people whose lives have been forever changed by cancer. The graphic on the right matches when the cancer was first diagnosed by the calendar year. The growing number of cases found with time is expected because with each year, our cohort increases in age and the entire year of accessions and enlistments are added into the cohort. Slide. Before we dive into the more results, let's briefly cover the statistical methods used. For our internal comparison, that is the micellar community versus the non-missile community from the Air Force, we calculated the incident rate ratios, or IRR. This is a direct comparison of cancer rates. For our external comparison, that is against the US population, we use the standardized incidence ratios, or SIR. This method allows us to compare our findings to national data from the National Cancer Institute's SEER program, while controlling for key demographic factors like age, race, and sex. Slide. For phase 2, we are using a forest plot to easily visualize each of these results. As an incident rate ratio or standardized incident ratio greater than 1 suggests there is an increased cancer rate in the missile community, while a value less than 1 suggests a lower rate. The key is to look at the horizontal lines, which represent the 95% confidence interval. If the entire line is to the right of the vertical, quote, line of no effect right at 1, then the increased rate is statistically significant, meaning it is unlikely due just to chance. If the line crosses 1, the finding is not statistically significant. Personally, I like to think about confidence intervals and the point estimates in the following way. We are very confident that the true value is along that line. The point estimate is often presented in the middle of that line, but our confidence is in the line. In fact, it's 95% confident it's in the line and not just the dot. Some of those lines are longer and some of those are shorter. Before I show the forest plots for our data, I would like to start up front with our findings. Slide. First, between the missile community and the Air Force non-missile community, or our internal comparison, we found an increased incidence of testicular cancer and Hodgkin lymphoma. However, neither cancer is typically associated with adult occupational exposures, but have well-established other risk factors. The phase 2 study will continue with an in-depth review of the specific jobs, time periods, and locations where feasible. Secondly, between the missile community and the U.S. population, or our external comparison, we found an increased incidence of melanoma. However, this higher incidence of melanoma is consistent with other cancer studies among the Department of Air Force and Department of War populations. Notably, non-UV occupational exposure is unlikely to contribute significant to melanoma. Again, the phase 2 study will continue as an in-depth review of the specific jobs, time periods, and locations where feasible. Slide. Now for the results of the internal comparison. Looking towards the bottom of the chart, you will see that we found a statistically significant increased incidence of both testicular cancer and Hodgkin's lymphoma in the missile community when compared to the Air Force non-missile community. For most other cancers, the incidence was statistically similar. Importantly, and for several cancers, including prostate, lung, and colon cancer, and the overall all 14 cancers when combined, the missile community showed a statistically significant lower incident rate. Again, the point estimate is the dot, but the line, the 95% confidence interval line, is the statistical analysis. The top line is the incidence of all 14 cancers studied, and then the cancers are listed by increasing incidence rate ratio. Of note, again, this does not include our North Carolina data that we just received this past week. After rerunning the analysis with North Carolina data, these precise numbers may slightly change, but the impact is unlikely to change the conclusions found on this slide. Next slide. Let's take a closer look at the cancers with increased incidence. Testicular cancer is the most common cancer found in men aged 20 to 34, but is highly treatable with a 95% survival rate. Research suggests that testicular cancer development begins during fetal development, particularly when prenatal exposure to endocrine disruptors interferes with normal hormonal activity. Major risk factors include a family history of the disease and undescended testes, which significantly increases the likelihood of developing a tumor later in life. The leading theory is that this testicular degenesis syndrome, or TDS, suggests that several of these risk factors have a single shared origin that all starts from hormonal disruptions while the baby is still developing in the womb. In addition, based on its current scientific literature, it is considered unlikely that adult occupational exposures are a significant contributing factor to this cancer. Next slide. Similarly, Hodgkin's lymphoma is a cancer of the lymphatic system. It is less common, but much more treatable than non-Hodgkin's lymphoma. It has approximately an 89% cure rate. Known causes include the Epstein-Barr virus and other genetic factors. The Epstein-Barr virus causes or is linked to infections like mononucleosis, or we know with mono, or other cancers, or some other autoimmune disease. Like testicular cancer, Hodgkin's lymphoma is not a cancer typically associated with any adult occupational exposure. Next, we compared the missile community to the general U.S. population. In this comparison, we found a statistically significant increased incidence of melanoma. That is the second from the bottom line of this graph. Most other cancers showed a similar incidence. Notably, the overall cancer incidence, along with the rates of testicular, colon, and prostate cancer, were significantly lower in the missile community than the general population. So even though we found testicular cancer incidence higher in the missile community than the Air Force non-missile community, both communities are still significantly lower than the general U.S. population for testicular cancer. Again, the top line is the incidence of all 14 cancers studied, and then the cancers are listed by increasing standardized incident rate ratios. As a reminder, we are very confident in the data presented here today, but with the addition of the final registry, the specific numbers will change. Transparency has been our goal from day one. Last week, we did not have the North Carolina data. We will rerun this analysis with an additional in-depth review of the specific jobs, time periods, and locations where feasible. Melanoma is a type of skin cancer primarily caused by exposure to ultraviolet or UV radiation. Research shows that this risk might be linked to more intermittent or intense sun exposures, like recreational sunburns, rather than steady daily exposure. Increased melanoma incidence has been found in other military groups. Most recently, the study on military aviators and aviation support personnel found melanoma incidence to be 75 to 87% higher in aircrew than the U.S. population. Currently, the National Institute for Occupational Safety and Health, as part of the Centers for Disease Control and Prevention, is investigating some of those risk factors in that population. While increased melanoma incidence has been noted in other military populations, the medical literature suggests that recreational UV exposures may play a larger role than an occupational UV exposure. For this study, we will continue an in-depth review of the specific jobs, time periods, and locations to also see what we can find any increased risk factors associated with melanoma in this population. Next, we have Dr. Timothy Crawford with us here today, here from the Wright State University. He's one of our external partners and working on the study with us. We wanted to give him a chance to introduce himself and describe his involvement with this study.
Thank you. Thank you for having me and allowing me to serve as an external reviewer. I'm an epidemiologist and biostatistician by training, so my involvement was to provide a third-party review to focus mostly on the study design, the analysis, the results, and the interpretation of those results. So thank you again for allowing me to be a reviewer on this important study. The team conducted a large epidemiological retrospective study to answer the following question: do members of the missile community have a higher risk of cancer compared to members of the non-missile community? The study had, from my review, a number of strengths to aid in the confidence of the results presented today. First, this was a very large cohort that allowed for more precise estimates of the incidence of cancer. Second, the study was enhanced from the first phase by including data from the virtual pooled registry cancer linkage system. The VPR captures 95% of the US population plus Puerto Rico. So this allows for the study results to be more generalizable to the target population. Additionally, the VPR provides accurate case counts, which does reduce the issue of misreporting or even underreporting of cancer cases. Another strength is the follow-up period, where the follow-up period ranged from an extended period of time, roughly 10 to 44 years, allowing for more time to capture cancer cases. And then finally, a strength that I believe is comparing the incidence within the community to the US population. That's the external comparison, which does allow to see if the incidence is greater or less than expected. The limitations of the study deal mostly with the issue of causality. In other words, can we determine a causal link from the study? The team were limited with the data that they were able to observe. The team adjusted for age, sex, race, and rank to reduce as much bias in the results as possible. However, there may be unobserved data that may contribute to the differences that were observed. This would be considered residual bias. For example, smoking, family history, and diet are associated with a number of cancers. So if one group were more likely to have a family history or more likely to smoke compared to the other group, that may be more explaining this increased risk that we may see and not necessarily the putative exposure. So although the findings are strong, I would be cautious in inferring a causal link. The next step of the study is to continue with subgroup analyses to identify which groups, like days of service or specific assignments, may be at more elevated risk or potentially might be driving some of the differences. I would suggest the team should a priori decide on which groups to focus on before diving into the analysis to reduce any bias, as well as to allow for reproducibility. I would just be cautious with this approach, as the more analyses you do and the more comparisons observed, you may increase the likelihood of falsely rejecting the null hypothesis. So I would approach this more as an exploratory analysis where the focus is on observing more of the risk effect sizes, so focusing on the risk ratios, and not necessarily on the p-values. So this could then lead to more hypothesis-driven studies, whereas another limitation here could be the diminishing sample size and power. So as you continue to drive down and focus on groups, you begin to lose sample size, which could lead to wider confidence intervals and more non-significant results. And so again, I would suggest the focus being on the effect sizes and whether or not the results are clinically relevant. So thank you.
Thank you, Dr. Crawford. In addition to our external academic partners, we are extremely proud to announce that 2 of our manuscripts detailing our methodology and initial findings have already been accepted for publication in peer-reviewed journals, specifically military medicine, later this year. Once published, we will ensure that those links to the articles are available on the MCCS website. With that, back over to Global Strike for the way forward.
Thank you, Dr. Crawford and Colonel Speakman and Dr. Duran for sharing your findings with us. So over the last 3 years, we've made significant progress. We remain committed to ensuring a safe environment through ongoing cleaning of our launch control centers, continuing our occupational health assessments, and sustaining our relationship with the EILER Working Group to expand and advance that capability. There are QR codes on the screen there for you to access both the EILER fact sheet as well as at health.mil to provide additional information with regards to EILER. As you heard, the epidemiology review will further analyze specific jobs, time periods, and locations. We will also continue our engagement and partnership with the VA and the Military Environmental Exposure Subcouncil, and the VA has remained a great partner throughout this process. Not mentioned earlier, I don't believe, but what was something that we accomplished recently was taking the cohort from the epidemiology study that we've been doing and sharing that with the VA so they can continue to monitor the same cohort that the USAF SAM team has been studying through the epidemiology review. Please continue to access our public-facing website that houses our reports, all the town hall events, the FAQs, and there's also an opportunity for the community to ask questions using a QR code also on the screen in the bottom right. Again, our commitment to your safety and our airmen and their families remains transparent and remains steadfast. Sir, over to you.
Right, I think we're prepared to do some Q&A, is that correct?
Sure.
All right, so Pierre, if you could read us the questions. And I would say as they're getting those ready, we may not be able to get to every single question. We'll try to see which ones are the most popular and significant. We'll try to answer those. But if you submit a question, we will answer that. So you'll be able to see that response.
Okay, the first question, does the study prove that working in the missile community caused my cancer?
Colonel Speaker, did you guys address that from the epidemiology review?
Thank you. Does this study prove that my cancers are caused by this? And no, this study does not prove that. This study shows an increased risk for 3 specific cancers. And we discussed them as testicular cancer, Hodgkin's lymphoma, and melanoma compared to the specific groups. There are many risk factors that go into contributing cancer development that include age, family history, genetics, personal lifestyle choices, environmental and occupational exposures, also infectious agents and other medical factors. We will continue to study on specific job categories, years of service, assignment locations, to see if there's any other perceived risk factor that we can further drive down to at this time. The current results suggest that increased cancers for the 3 cancers, as I talked about. Across the current and historical ICBM bases who served between 1976 and 2010. Ultimately, the ongoing analysis may narrow down this down to the members of the missile community who served during certain years at certain bases during certain jobs, but we are not there or ready to talk about that level.
Right, thanks for that answer and thanks for the question. PA, next question, please.
What do you mean by association and causation, and what are the differences?
Yeah, so association is a statistical relationship between a couple of variables. Exposure is an outcome, such that they occur together more frequently than would be expected by chance. Associations are quantified in the MCCS by measures of effect, such as the incident rate ratios or the standardized incident ratios. An association might be causal, but it also be spurious, which means it's just due to chance. It could be an artifact, meaning it's due to the study design, or it could be a confounder where the variable is independently associated with both the exposure and the outcome. So causation really implies a relationship between the factors, such as you served in the missile community, and the outcome, such as you got cancer, where the factor directly causes the outcome. Greater than 99% of the time, cancer cluster studies such as this one do not demonstrate causation. The other way to think of association is things are just happening together. For example, there's a massive statistical association between people carrying umbrellas and it's raining outside. If you look at the data, every time people have umbrellas, it's usually wet outside. But the umbrellas do not cause the rain. If you open an umbrella on a warm, sunny day, it does not start suddenly pouring outside. So that is where associations are related, but they are not, one does not cause the other.
Right, thanks for that answer. PA, next question, please.
Will the next phase of the study prove that my job, 13N, missile air, caused my cancer? When will you have those results?
Again, proving cancer is very difficult, as both Dr. Crawford talked about, and understanding the differences between causation and association. But we will continue the epidemiological study of this portion will not prove that your job caused the cancer. The missile community study will advance with the additional review. We're going to focus on specific jobs, specific time periods, and bases to see if those associations are increased of cancer incidences on those groups. This portion of study will be able to focus on trends more than specific subgroups of the missile community. The portion will continue our commitment to the health and well-being of the missile community by ensuring a comprehensive and accurate understanding of our findings. The results are expected to be available by the end of this summer.
All right, thanks for that question and answer. PA?
Are you saying that burning materials in an enclosed environment is safe?
So I would never say that burning materials in an enclosed environment without adequate ventilation is safe. While this was the de facto standard way to dispose of crypto tapes in the past, Air Force Global Strike took immediate action to issue a burn memo and stop all burning based on the recommendations from Yusuf Sam several years ago to cease burning activities after visiting the missile bases with the active nuclear deterrent mission. Importantly, the burn study conducted here by the 711th Human Performance Wing burned several mixtures of materials under a variety of conditions that missileers would have experienced. They measured the chemical emissions and concentrations using industry standard practices and well-described methodology. The burn study found that excess cancer risks for all burn experiment conditions were less than the accepted occupational threshold of 1 in 10,000 causes of cancer. To put that in perspective, the American Cancer Society estimates that smoking cigarettes leads to a lifetime excess cancer risk of nearly 810,000. So while the past practice of burning materials in an enclosed environment cannot be recommended, the results from the burn study suggest this does not statistically increase excess cancer risks. Furthermore, although the negligible effects as defined by the Defense Centers of Public Health of military exposure guidelines, such as eye and respiratory irritation, did exceed occupational standards, those effects were short-term and reversible.
Right, thanks, back to PA.
When will the Air Force recognize those military members who served prior to 1976 and ensure their access to applicable data so they can connect the dots to their issues? The ILR was not available for older missile or AFSCs because the VA stated I had no toxic exposure, yet my hematologist and research oncologist identified my MDS-RS as logically connected to the exposure I've received via my military service in missiles. Over.
So I think there's a couple of ways that we've been addressing this. First, as I mentioned, through the occupational health shops that we have generated for those serving in the missile fields today, we are capturing all of that data and making sure that it's in the DOOR system and it links to ILR. The second piece is being able to access your individual longitudinal exposure record and the additive feature now where you can add information to your ILR helps to build a comprehensive exposure record that you can use with your healthcare provider for the individualized care for your healthcare concerns. We also have provided, as I mentioned earlier, the PCB memo that's on our missile community website that identifies the presence of PCBs in the environment going back from the 1990s. It covers all the weapon systems where we had ICBM operations from 1970 up through active missile fields today. And then lastly, we're continuing to work on a comprehensive list of potential exposures from all the weapon systems, and we'll produce another memo that you can use with your healthcare provider to show what hazards you may have been exposed to and share that for your individualized healthcare.
Greg, if I was a historic missileer serving in Atlas or Titan and I add in ILR, that exposure, does that tie to the specific things that we expect that missileer was exposed to, or is that, will they have to match that with a letter? How will that work?
Well, we're also working with the ILR working group for the ability to insert attachments to the Add My ILR portion of that. So ideally, or in the future state, we'd be able to take the memo that was comprehensive, had all the hazards, and then associate with that particular weapon system as they handle that information to ILR. So they would be able to connect those two dots for that discussion with their healthcare provider.
Okay, and will that link back into VA? Because part of this, I think part of the question is linking to VA so they have that exposure so they can make a determination on if it's service connected or not service connected.
Absolutely. So the ILR system is set so both Department of War and the VA have access and can see the information that's in there by individual. So if you have access, the VA already has access to ILR and they can see you in the system.
Okay. All right, PA, next question, please.
That is all the questions, sir. Over to you.
All right, and thanks for joining us for this update. As was kind of clearly pointed out in the briefing, we still have more work to do on this next phase. We're going to go with the North Carolina data and rerun those numbers to see what, if anything, changes, and we'll update all that information. And then also we're going to go back, as was clearly articulated by the USASAM's team, and look at specific AFSC's bases and timeframes to see if there are any associations that we can discern from that. And those are the important next steps. I'd like to thank you for joining us. Once again, there are ways that you can ask us questions. If you didn't get a chance during this, you can submit those questions. We'll get your response. And then you saw from USASAM's, I think the fall is when we're looking for the next block of data to come out. And we'll schedule another town hall at that time. Follow the website. That's where you get the best, most accurate information, and we'll keep you up to date via the website. Once again, thanks for joining us, and let us know if you have any questions. Out from Barksdale Air Force Base.